Bismillahirrahmanirrahim. Assalamu alaikum. I'm Dr. Zia. I welcome all of you from Master of Medical Knowledge Hub for today's lecture of fluid balance in surgical patients. Fluid balance is a very important aspect in perioperative management of surgical patients. Broadly, we can classify the intravenous fluid resuscitation fluids into two categories. One is the crystalline fluid and second is the colloid fluid. If we notice the various characteristics of these fluids, intravascular persistence is poor in the crystalline, but it is good in the colloid. Hemodynamic stabilization is transient for the crystalline, but it is prolonged for the colloid. Crystalline requires the larger infusion volume and colloid as compared to colloid, but the risk of tissue edema is more in the crystalline, but is insignificant in the colloid. Capillary enhancement of capillary perfusion is poor in the crystalline, but is good in the colloid. Risk of anaphylaxis is nil in the crystalline and low to moderate in the colloid. While the plasma colloid osmotic pressure is reduced if we infuse the crystalline, but it is maintained with the colloids. But very important in clinical setups that crystalloids are inexpensive and colloids are expensive. So these two parameters, that the inexpensiveness of the crystalloid and the no risk of anaphylaxis, usually crystalloids are preferred. Otherwise, if we notice the parameters, colloid has good spectrum of different parameters. So some discussion of some other fluids, for example, the 5% dextrose solution. It is an isotonic solution and it is used mainly for the calories purpose, but it is deficient in electrolytes. It is usually used in the immediate post-operative period because, as we know, that in the immediate post-operative period, there is a renal conservation of the sodium ion, and sodium excretion is relatively diminished. So if in these patients, in the immediate post-operative period, if you use sodium-containing fluid, patient can go into the hypernatremia. So 5% dextrose solution is the preferred fluid for the patients in the immediate post-operative period. But if we give this 5% solution for a prolonged period, it may lead to the hyponatremia because it is deficient in the electrolytes. There are some other formulations of dextrose available, for example, dextrose 10%, which are usually used for the prevention and correction of the hypoglycemia, and dextrose 25%, which is also used for the hypoglycemia, and dextrose 50%, which is also used for the hypoglycemia. So this dextrose 10% is normally used in the total parenteral nutrition formulations, and this dextrose 25% is normally used in the diabetic patients which presents with the hypoglycemic episodes. Then the normal slide, which is the 0.9% saline solution or isotonic saline solution. This concentration we already discussed in the previous slides. This saline solution contain, in addition to the water, it contains the sodium and chloride ions, and other advantages, the osmolarity of this isotonic saline solution is closer to the extracellular fluid osmolarity. So there is the shifting of the fluid across the compartment. Chances of shifting of the fluid across the compartment is less. It is used for replacing gastrointestinal losses, which may be either due to the vomiting or due to the nasogastric aspiration or intestinal fistula. But as we have already discussed in the previous slide, that in the immediate post-operative period, as there is the natural conservation of the sodium, so immediate post-operative period, normal saline or isotonic saline solutions are not used. And 5% dextrose water solutions are used for the energy purpose or the calories purpose. It imposes an appreciable load of excess chloride on the kidneys that cannot be readily excreted, that we've discussed. And this solution is ideal to use in the extracellular fluid deficiency, especially if there is associated hyponatremia, hypochloremia, or metabolic alkalosis. So in these conditions, the fluid of choice will be the isotonic 0.9% saline solution. Then the dextrose normal saline, which is also known as DNS solution. In dextrose normal saline solution, there is a 5% weight by volume dextrose. There is 0.9% weight by volume sodium chloride. This solution is used to raise the total fluid volume and to correct the hypoglycemia at the same time. It is also used as a vehicle for the administration of drugs, which we have to give in a dilutional form. Lactated Rinder solution, these concentrations we have already discussed in the previous slides. The main advantage of Rinder's lactate solution is the almost similar electrolyte concentration as extracellular fluid, and the pH remains normal even we infuse a larger quantities of these fluids. So this is the best fluid for the hypovolemic shock. But also remember that the best fluid to be replaced is the fluid which is lost. For example, if the patient is having a hemorrhagic shock and the blood is lost continuously, we have to arrange the blood for the patient. But in the meanwhile, the time which is the waiting for the blood, in that time we can use the Rinder's lactate solution. And the chief disadvantage is it has a slight hypoosmolarity with respect to the sodium. It is also suitable for the gastrointestinal fluid losses. Darrow's solution. This is the only solution which contains more potassium than available in the plasma or extracellular fluid. The potassium concentration in the Darrow solution is about 36 milliequivalent per liter. Sodium is 124 milliequivalent per liter and chloride is 104 milliequivalent per liter with the lactate 56 milliequivalent per liter. It is the best solution to combat the hypokalemias, decrease in the serum potassium level. If we need to replace these levels along with the fluid, we have to use the Darrow solution. The rate of IV infusion should be slower than the other solutions to avoid the hyperkalemic state. Because we know that the potassium is a very important ion and the target muscles are very sensitive to the potassium levels. Either the potassium levels are lower or the potassium levels are higher than the normal. Both are cardiotoxic. Both can lead to the arrhythmias. So hypokalemia as well as hyperkalemia is arrhythmogenic. So we have to replace these with very much caution and care. This solution should be given when the gastrointestinal losses or when the gastrointestinal losses are being replenished with the isotonic saline solution and Rinder lactate solution for a considerable period of time. We have two options in such cases. Either we have to add the potassium chloride solution in the isotonic saline or Rinder lactate solution, or we have to shift to the Darrow solution. Then the mannitol. Mannitol is the solution of mannitol in water or normal saline. It is used to raise the intravascular volume. It's used to restore the interstitial and intercellular edema. It also promotes the osmotic diuresis. Then the colloid. Colloid are used in the surgical patients as a volume expander. As we have discussed in the previous slide, due to their larger molecular weight, they are confined to the intravascular space and their infusion result in more efficient transient plasma volume expansion. Colloid solution with smaller particle and lower molecular weight exert a greater oncotic effect, but are retained within the circulation for a shorter period of time than the larger and higher molecular weight colloids. Most common colloids used are the hemacil, which is used to expand the plasma volume. Thank you very much for today. Next time we'll meet in the next topic.